Good morning. My name is Paulette Cha, and I'm a research fellow at the Public Policy Institute of California. Thank you for tuning into our program today, featuring the findings of my new report, Health Coverage and Care for Undocumented Immigrants in California, co-authored with my colleague, Shannon McConville. The report, as well as the slides from today's presentation, are available on our website at ppic.org. We would like to thank the PPIC Corporate Circle and the PPIC Donor Circle for supporting today's virtual event. As a public charity, PPIC does not take or support positions on any ballot measures or legislation, nor does it support, endorse, or oppose any political parties or candidates for public office. For today's program, I will present some key findings from the report, and then I will answer questions from the audience. If you have a question about the report, please send an email to the address on the screen, ppiceventquestions@gmail.com. We would appreciate your including your name and organization along with your question. And with that, I will begin the presentation. So, Health Coverage and Care for Undocumented Immigrants in California, an update. As you can tell from the title of this report, it is an update to previous work we have done on health coverage and care for undocumented immigrants. However, this report reflects the changing policy context for undocumented immigrants in recent years. It also comes at a time when Californians are increasingly recognizing undocumented immigrants as important members of the state's workforce, communities, and families. In the report, we analyzed what health insurance coverage and access to care look like for undocumented immigrants. Our report discusses their health insurance options, which are limited compared to those of other immigrants. We cover where undocumented immigrants go for healthcare. As it turns out, they frequently go to healthcare safety net providers. We also discuss their potentially unmet health needs. And finally, we document some differences within the state. For this project, we primarily used the California Health Interview Survey. The survey is run by UCLA, and it has a representative sample of Californians. It collects information on health insurance, health needs, and demographics, including information to identify likely undocumented immigrants. Undocumented immigrants who are low income or under 200% of the federal poverty line are less likely to be insured, and they are much less likely to have employer insurance compared to higher income undocumented immigrants. Because of this, we focused our research questions on low-income undocumented immigrants who lack coverage and presumably have greater barriers to care as a result. Low-income naturalized citizens and green card holders serve as the comparison group for undocumented immigrants in our study. We focus on adults over age 19, since for our time period, these adults did not typically have access to comprehensive Medi-Cal, which is our state's Medicaid program. The chart here illustrates that among low-income immigrant adults, citizens and green card holders have much lower uninsured rates compared to undocumented immigrants. Moreover, much of the coverage reported by undocumented immigrants is likely to be a limited version of Medi-Cal that is not comprehensive health insurance. So let me turn now to why undocumented immigrants are so much less likely to be insured. There are a number of barriers. Undocumented immigrants are ineligible to purchase health insurance on Covered California, which is our state's marketplace established under the ACA, also known as Obamacare. There's actually a federal bar on their purchasing coverage on the exchange. They're also typically not eligible for the comprehensive version of Medi-Cal, which we'll get a little bit more into later in this presentation. Undocumented immigrants, as I mentioned previously, tend not to have employer coverage. They can purchase their own private health insurance off of the marketplace, so on their own, but it tends to be a cost-prohibitive option. Immigration-related concerns, including the previous presidential administration's efforts to expand the public charge rule to cover more scenarios, caused concerns and a depressed take-up of public programs, even among the eligible. There may be consequences of these barriers for children, the vast majority of whom are US citizens, if they are members of mixed status families. By this, I mean children with at least one family member, often a parent, who is an undocumented immigrant. Children may have lower levels of insurance coverage and access to healthcare associated with their family members' immigration status. The healthcare safety net can be uneven for undocumented immigrants. Age turns out to matter quite a bit for coverage, at least with respect to Medi-Cal eligibility. Since 2016, undocumented children have qualified for comprehensive Medi-Cal, so the full health insurance. Since 2020, you may have missed this because 2020 was consumed by the pandemic, but young adults have also had access to Medi-Cal up to age 26. Seniors are also going to be Medi-Cal eligible regardless of immigration status soon. The specific age range is being negotiated right now between our governor and our state legislature, but we expect to see senior coverage coming soon. Counties are required to be the healthcare provider of last resort for their medically indigent residents who neither have health insurance nor can afford the cost of care. However, not all counties cover the undocumented in their programs. Some major ones, such as Los Angeles, where a large proportion of the state's undocumented immigrants reside, do cover all residents regardless of immigration status. And specific health needs can also confer eligibility for Medi-Cal. So these are just some broad stroke differences, but as you can imagine, even in a single family unit, there can be various degrees of eligibility and access. So here is an example of Medi-Cal for a specific age group. A policy change in 2016 allowed undocumented children to qualify for the comprehensive version of Medi-Cal. The geographical distribution of enrolled undocumented Medi-Cal children differs across the state, but to be clear, this is not the product of policy, but rather where undocumented children are more concentrated among child populations. I want to point out that we don't see the percent of children covered exceeding 3% in any county, and this makes sense because the vast majority of California's children, including the vast majority of children in our state's immigrant families, are US citizens. And here now is an illustration about geographical differences in how counties include or exclude undocumented immigrants. About 2/3 of the undocumented immigrants in our study live in counties that include them in their medically indigent programs. It's not shown on this map, but I need to mention that these county programs are not all the same. Some are more basic, while others are more robust and integrated systems. LA County's My Health LA bears mentioning here as one of the more robust county health programs, along with Healthy San Francisco. Interestingly, despite these considerations and the variations by county, we did not find that county indigent program differences alone were associated with differences in access to care among undocumented immigrants. Now let's discuss some of the specific things Medi-Cal covers for patients who are otherwise ineligible due to immigration status. Emergency-only Medi-Cal allows for limited scope coverage of medical emergencies. Specific healthcare needs, like dialysis for end-stage kidney disease patients, are covered. Again, though, these are more akin to emergency health services. Prenatal and postpartum care are covered under a policy option that recognizes these services contribute to the health of the in utero or newborn baby who is a US citizen. In addition, Medi-Cal has programs for specific types of health needs that cover all Californians. For example, breast cancer screening and treatment and family planning services are covered for all. Past research has found that undocumented immigrants use less healthcare and spend less on healthcare. In fact, cost is a deterrent for undocumented immigrants in seeking care. This was true before the ACA passed, and the ACA mostly avoids addressing the undocumented population. So it is reasonable to expect that after the law passed, other immigrants have actually had improvements in access, further widening the gap between themselves and undocumented immigrants. In our analyses, being undocumented was associated with missing healthcare due to cost among those who had missed getting healthcare for any reason. And when undocumented immigrants do get care, it tends to be primary care. For example, in LA County's program for medically indigent residents, the majority of visits are for primary care. So this would be routine care that we would expect all individuals to access at least annually. And finally, note that the lack of regular engagement with the healthcare system is likely to result in undiagnosed conditions. When individuals report their health status, they may not have all the information about themselves if they have not been receiving regular healthcare. Being able to identify a usual source of healthcare is an important measure of access to care. Overall, low-income immigrants are likely to have a usual source of healthcare. About 3/4 of immigrants in our study have a usual source, but there are differences by immigration status, as you can see in this graph. Even when we control for multiple factors in our analyses, undocumented immigrants are disadvantaged. They are about 9% less likely to have a usual source of care compared to other immigrants. Also in our analyses, we find that undocumented immigrants are about 17% more likely to report a safety net healthcare provider as their usual source. And by this, I'm referring to public hospitals, community clinics, or ERs. Note, however, that the ER by itself does not emerge as a usual source in a meaningful way. ER use is a question that we tested in many slightly different ways, but we did not find evidence that any groups of immigrants tend to favor the ER as their usual source of care. And moreover, our adjusted analyses do not find undocumented immigrants report more ER use than other immigrants. It's quite similar. So returning now to the question of whether undocumented status affects children in the family. We looked at children in mixed status families compared to children in other immigrant families. Overall, children are quite likely to have a usual source of care. This is good news from a children's health standpoint. However, children in mixed status families are 11% less likely to have a usual source. We cannot say for certain that family undocumented status is definitely the reason, but our analyses do control for a range of individual geographic and temporal factors. So does the status quo look likely to change? Our state's leaders are working to improve access to coverage and care for undocumented immigrants in California. In addition to recent expansions of full scope or comprehensive Medi-Cal to undocumented children and young adults, policymakers are planning an expansion for senior citizens regardless of immigration status. There's also a bill to expand some private insurance plans to cover undocumented parents that would be similar to how young adults can get dependent coverage on their parents' health insurance. And the state's Healthy California for All Commission is charged with coming up with ways to expand coverage and care to all Californians, including undocumented immigrants. The PPIC statewide survey finds that these policy efforts reflect the evolving public opinion of Californians, who increasingly support health insurance coverage for undocumented immigrants. In 2021, 66% of the state's adults favored providing healthcare to undocumented immigrants, and that was up from 54% in 2015. While we find that undocumented immigrants do face barriers to coverage and care, the state's policy efforts are aiming to increase access. Thank you so much for your interest in this project, and I'm happy to take a few questions from the audience now. You can submit your questions to ppiceventquestions@gmail.com. Okay, I see we are getting a question, and it is from an audience member in Sacramento. And the audience member asks, why are popular opinion and policy making shifting to favor more coverage for undocumented immigrants recently? So it's hard to explain exactly what's happening with popular opinion, but it does seem to be a trend that has been going on for several years. I will note that California has been taking the lead in integrating undocumented immigrants into broader society at a time when the federal government has been at an impasse with respect to passing comprehensive immigration policy reform. So it could be some of California's leadership role in terms of the policy changes, I would say most recently, public opinion and policy may be shifting in that direction due to, frankly, the experience of COVID-19. During the pandemic, we learned that immigrant communities were being hit very hard by COVID-19. We also learned, due to the pandemic and the way that it spread, that lack of testing, treatment options, and preventive care, including vaccinations, affect entire communities, not simply individual undocumented immigrants. And finally, there could be changing public perceptions in response to the fact that immigrants had high representation in the essential worker labor force that did continue working and circulating in the community during the pandemic. Okay, I have another question, also from an audience member in Sacramento, about whether I have evidence that undocumented immigrants are not getting needed healthcare. So that is a really good question, and I think that that's one that we also at PPIC would like to be able to answer better. And I say that because it's hard to know from a survey whether care that was received or perhaps even care that was missed was needed or not. This is all based on self-report. But we did learn through our analyses that undocumented immigrants are less likely to have seen a healthcare provider at all compared to other immigrants. They're also less likely to have had a routine physical. So that's the thing that you would want every adult to receive on an annual basis. And as we saw previously, they're less likely to report having a usual source of care. And that part was also true for children in mixed status families. But on the other hand, undocumented immigrants in the survey report missing health care at rates that are similar to other immigrants. And that was also the case for reporting missing, picking up a prescription. So it's very hard to say for sure. There is some suggestion, especially around the not getting routine physicals, that they may not be receiving the baseline level of care that all individuals should get annually, but we can't say for certain that there are specific healthcare needs not being met. Okay. Another question from an audience member in Sacramento, and the audience member asks, do you know if cost was a barrier to getting healthcare for immigrants in your study? So I just mentioned that undocumented immigrants missed care at rates that were similar to other immigrants. But among those who did miss care, they were more likely to report cost as the reason why they did not get health care compared to other immigrants. So that does suggest that cost is a barrier. Of course, cost is tied up closely with insurance coverage status, and we know that undocumented immigrants have much lower rates of being insured, and certainly of being insured on comprehensive healthcare plans. So it does seem likely that cost is a barrier, and those conclusions would be consistent with past work that we've seen in the literature. Okay. Audience member from San Mateo asks, will we share the presentation? And I believe it is already on our website. And if it's not, it will be there very shortly. So yes, the slides will be available. And I think this is also being recorded and will be posted to the website for viewing later. Okay. Let's see. I have an audience member from the Bay Area saying there was a clear welcome mat effect of the expansion of Medi-Cal to all low-income adults in 2014 and after for children. Is there evidence that citizen children with undocumented parents missed out on this welcome mat effect? I think that's a really great question. We did not explore that question. The survey that we used, we primarily focused on adults because that was the largest portion of who's surveyed. The child sample wasn't huge, so we only asked a few questions that we thought we would be able to answer with confidence, but we did not explore that particular question in this study. But I think that that is a really good one to probe on. So I see a question from Maya Clausen from Washington, D.C. And Maya asked, could you share the primary barriers to undocumented immigrants receiving healthcare and how this differs across groups? Pardon me, I'm not sure exactly what you mean by groups, but I will say that when we looked at all undocumented immigrants in California, as opposed to only the low-income group, I was really struck by the fact that the higher income undocumented immigrants, and there are some in California, had, I think, about a 50% employer supplied insurance coverage rate, which is to say that the higher income undocumented do have access to a fair amount of employer insurance. And so I think that looking at undocumented immigrants by income status, it's clear that there are barriers for the lower income group in terms of accessing that source of health insurance coverage. We do think, as I said previously, that cost is likely to be a barrier and that would be consistent with other work. We didn't look at a comparative analysis of different reasons why individuals, say, missed getting care or didn't have a routine exam. But we've had some other conversations for planning work for other research also in this space, where we have heard things from immigrant serving organizations about concerns about finding appropriate transportation, needing to leave work during the day, so doctors not being available when patients are not working. And then specifically around the vaccine, we had heard some concerns about potential side effects of the vaccine, and again, not being able to report for work as a result of that. So I think that the reasons for there being barriers to care are quite wide-ranging and can be idiosyncratic, but there are some broader themes for this community. So I see an audience question from the Stanford Immigration Policy Lab. Elisa Cascardi asks, wondering if employment status or job type correlates with health outcomes in your study. Thank you. So that's interesting. I will say that we didn't look specifically at employment status or job type, although undocumented immigrants do work at very high rates. In fact, you could argue that they are here in order to work. I say it's interesting because what we have in terms of health outcomes is largely self-reported. It's entirely self-reported. And in terms of self-reported health, the undocumented immigrants were very similar to other immigrants. And again, that can reflect what is known or not known about one's own health status, especially among those who have not been receiving regular care. So if, for example, older immigrants have been avoiding healthcare for any number of reasons or just unable to access care, they may have undiagnosed conditions that they are not able to report to a survey versus, say, those individuals who have been receiving care regularly, getting their routine exams, getting needed screenings, and so on. And so so we did look at health outcomes, self-reported health, self-reported diagnoses, didn't see a lot of huge differences across the different immigrant group types. We did not test that by employment type, but we did look by immigration status, and didn't really know how to interpret that because, again, it's self-reported and people may not have full information about their own health status. I think that that type of question is exactly the sort of thing that we would like to try to get into understanding better. And I think that what's needed to do that well is more clinical data, more sort of expert opinion or diagnoses or medical records or encounter data on actual patients who are likely to be undocumented and not self-reported information. So I see another question. This is from Valerie, who asks, is there a source you recommend for looking at policy rollout in specific counties? I'm not sure exactly which policy you're referring to. If you are referring to the medically indigent programs that I referenced and showed in the map, those programs were rolled out a long time ago. They're not recent changes, but there are some resources. I think the California Healthcare Foundation has a report that's a couple years old. There's also a resource from the Uninsured project, maybe a 5 or 7 pager on those programs and differences across the programs. As I mentioned, they are quite different in terms of they're able to set eligibility criteria, benefits and services. They can directly deliver the health services to their medically indigent residents, or they could just be payers to other providers. So, and I think there's also a version where some counties do some of each of that model. So that could be a resource if that's what you're looking for. If it's something else specific, some other kind of policy, I would say, let me know. You can get in touch with me by email and I can try to find something for you. So there's a question from Gregory Mathis, Director of Programs and Policy at the Community Health Initiative of Orange County. And Gregory says, from our experience on the ground, it seems that a major barrier to accessing health insurance and healthcare have been concerns related to the public charge rule. I think that sounds likely to be very accurate, and one's path to citizenship. Can you please comment on this? I would say that based on those other conversations that I mentioned having for research planning work, that sounds very accurate. I think the thing with the public charge rule is that the proposed changes to the public charge rule would not have affected a lot more people, but those changes were so complex and hard to understand that they generated a lot of confusion and a lot of fear that made individuals wary of engaging with public programs, even if they themselves would not have been affected by the change to the public charge rule as it was proposed. And so I think that if the proposed change to the public charge rule was to depress participation in programs such as public health insurance or other safety net programs, that goal may have been achieved. It has been achieved regardless of its actual implementation, because what it did was it kind of created a really big fear cloud around public programs, regardless of whether one would be directly affected or not. So it is consistent with what we're hearing from those closer to the ground. We don't have information, or at least I'm not aware of anything in the survey that would have probed specifically on the public charge rule and fear around participating, say, in Medi-Cal or county provided health care services. So that's all the questions as of now. So I'll say that we've reached the end of our program. And I'd like to thank again our funders, and thanks to all of you for joining us today online. If you pre-registered for this event, later today you will receive a survey, and we hope that you'll take a couple of minutes to respond and let us know how we did. Please be safe and have a good afternoon.